Dear audience, thank you for coming today. Let me introduce my PhD topic, which is novel insights into the oral systemic health axis. My name is Ellay Gutmacher. I'm a fourth-year dental student and first-year PhD student. My supervisors are Andrea Brody and Ako Gembri. My SMS is Petrana Martinakova. My vision is to facilitate global healthcare by better understanding the oral systemic health axis, and my mission is to do that by providing a scientific evidence that supports that saliva is efficient enough to detect systemic diseases. Currently, we have 3 ongoing projects. Due to time limit, I will talk about only the first 2, but the last one is evaluating the levels of CRP in neonatal sepsis. So my first project is investigating the salivary levels of Fusobacterium nucleatum in patients with colorectal carcinoma. This is done by the methodology of systematic review and meta-analysis. It has started in September this year. So colorectal cancer causes more than 930,000 deaths per year. It is estimated to grow to more than 1.6 million deaths by the year 2040 worldwide. Screening tests, such as colonoscopy, can prevent early colorectal cancer by detecting malignant polyps and removing them. However, unfortunately, colonoscopy has its limitations, such as the geographic barrier, and this contributes to the late diagnosis of colorectal cancer. In addition, it is an invasive, uncomfortable, and potentially harmful procedure, which may also contribute to it. As an example, in the USA, nearly 22 million risk individuals between the ages of 50 to 75 have never been screened for colorectal cancer. We know that Fusobacterium nucleatum is an oral pathogenic bacteria that is associated with periodontitis. It was found that it also accelerates carcinogenesis in different types of cancers, such as breast cancer and pancreatic cancer. Recent studies also show that this bacteria is found in colorectal tissues of patients with colorectal cancer and polyposis. And the higher the abundance of the bacteria in those tissues, the lower the survival rate of the patient. Therefore, we suggest a novel method to detect colorectal cancer by using saliva samples from which we can quantify the DNA levels of Fusobacterium nucleatum. Our vision is that risk individuals would be able to be diagnosed early from home by using simple saliva samples. And by that, we provide an excellent tool to increase the detection rate of colorectal cancer. And this is why we aim to investigate the diagnostic and prognostic accuracy of salivary Fusobacterium nucleatum in patients with colorectal cancer. So we ask, is there a difference between colorectal cancer and healthy or precancerous patients in the salivary Fusobacterium nucleatum DNA levels? We use the PECO framework and the PERT framework. The PECO framework is for to investigate the association between salivary Fusobacterium nucleatum and colorectal cancer, and we hypothesize for this that patients with colorectal cancer have significantly higher levels of salivary Fusobacterium nucleatum than patients who are healthy, as well as patients who have precancerous lesion. And we use the PERT framework to investigate the accuracy of salivary Fusobacterium nucleatum to detect colorectal cancer. For that, we hypothesize that salivary Fusobacterium nucleatum can accurately diagnose colorectal cancer. And our clinical implication that salivary Fusobacterium nucleatum can be used to detect colorectal cancer patients. We conducted our systematic search on November 25th in 4 databases with the following search key, as you can see on the slide, composed of 4 domains. We started with 14,000 studies, and currently we are at the stage of title abstract selection, and I wait for the opinion of my co-investigator to finish this part. My second project is investigating the diagnostic accuracy of salivary procalcitonin in bacterial-induced systemic inflammation, and this one is a clinical observation. It has started in November this year. So we know that bacterial infection cause more than 50% of infections in the ICU in the critically ill patients. And we also know that infections in this type of patients is associated with high morbidity, high mortality, and high cost. The used method to detect the source of infection is a bacterial culture, but also this method is quite slow. It may take several days to get an answer, and quite frequently it gets contaminated on the way to the lab, which makes the whole sample inefficient. Diagnostic strategies to exclude the presence of infection, therefore, are urgently needed. We know that serum procalcitonin is a very sensitive biomarker to detect the bacterial infection. By excluding bacterial infection, it can prevent the misuse of antibiotics, and by that reduce the excessive use of antibiotics and also fight antibiotic resistance. Also, studies show that procalcitonin is high here in patients with periodontitis, as well as patients with acute exacerbation of chronic obstructive pulmonary disease. So our aim is to investigate the diagnostic accuracy of salivary procalcitonin to detect bacterial-induced systemic inflammation. Our first clinical question is, how does the salivary procalcitonin correlate with serum procalcitonin in patients with suspected bacterial infection? We use the PECO framework to answer this question. And our hypothesis is that salivary procalcitonin does correlate with bacterial-induced systemic inflammation. Our clinical implication is that salivary procalcitonin could indicate systemic bacterial infection and also the need for antibiotic therapy. Our second question is that could salivary procalcitonin accurately predict bacterial-induced systemic inflammation? For that, we use the PER framework to investigate the accuracy of salivary procalcitonin, and our hypothesis is that salivary procalcitonin can accurately predict bacterial-induced systemic inflammation. And it has the same clinical implication as the previous question. So for summary, we plan to finish with all of our projects early next year. And I would like to thank you for your attention with the words from Albert Einstein. The most beautiful thing we can experience is the mysterious. It is the source of all true art and science. Thank you.
I would like to ask, how do you want to measure that the rise of procalcitonin level is due to periodontitis and not due to other systematic infections?
Oh, thank you so much for your question. So actually, this is exactly why we want to conduct this research. We want to see whether the procalcitonin in the saliva correlates with the procalcitonin in the serum. And by that, we would be able to conclude the different conclusions. But this is the answer.
It was really good to hear that you have a similar interest as I do in the levels of procalcitonin. What do you consider oral procalcitonin bringing as a plus diagnostic method compared to serum procalcitonin levels, if found that they correlate really well?
Yeah, so your question is like, why do we investigate the salivary procalcitonin in the saliva when we already have...
Yes.
Yes, exactly. Okay, so the reason for that is that eventually our vision is that patients, we want to measure actually the procalcitonin in the saliva in different time points. And for that, it is much easier to do it from the saliva. As an example, in the winter when there are a lot of diseases and respiratory infections, a lot of patients come to the primary care, and let's say that the doctor would test the salivary procalcitonin in the patient, and then 12 hours later, just as a hypothesis, 12 hours later, the patient would be able, with a tube that doctors gave to him, he would be able to see the result of his procalcitonin at home, and then to inform the doctor, and the doctor would be able to see the difference, and by that, he can tell him you can take antibiotic, or you can, it's a viral infection, you don't need to take it. So that's why we want to investigate salivary procalcitonin when we already have a serum procalcitonin.
I have a question about your first topic. So let's say that the test can detect the colorectal cancer. And which part of the population would you think that will benefit the most from this test?
Thank you for your question. So according to the guidelines, the risk patients for colorectal cancer, basically it's 50 to 75 or more, so adults, of course. As I mentioned, the biggest problem with these risk patients is that the geographic barriers, because it's not so comfortable to go to do a colonoscopy, it's invasive, it requires a partial anesthesia, and this is why we want to adapt it to these risk patients.
You mentioned that there's an existing screening method, colonoscopy, with a lot of drawbacks, but you didn't mention the other screening method, which is a stool blood test.
Yeah.
And sorry?
Could you just repeat your first sentence? I couldn't hear.
So you mentioned the screening method, colonoscopy, with a lot of drawbacks, but there is another screening method widely used, the blood stool test, which is sensitive and is cheap. So I believe it's widely available, maybe even cheaper than the saliva test. So is there anything that this saliva test can add to this, or is there anything that this saliva test is superior compared to the blood stool test?
Thank you so much for your question. It's a really good question. So yes, I was also thinking about it. We were all thinking about it. Fecal samples, as you said, are very good. The problem, small problem, is that usually those samples are positive only in late stages when the cancer is already there. This is one aspect. But the other aspect, we also want to investigate whether this Fusobacterium nucleatum, which is known as a pathogenic bacteria in the oral cavity, is actually originating from the oral cavity and coming from to the colorectal cancer via the blood. If we will figure out something about it, I think it will be a good process, because maybe this will be the reason for colorectal cancer, for example.